Hello and welcome. I'm Dr. Eric Darr, and on behalf of CME Outfitters, I would like to welcome you and thank you for joining us today for today's CMEO briefcase entitled Prior Treatment Failure, Addressing the Challenge in HIV Care. This program is supported by an educational grant from Gilead Sciences. I'm the chief of the Division of HIV Medicine at Harbor-UCLA Medical Center, an investigator at the Lundquist Institute, and a professor of medicine at the David Geffen School of Medicine at UCLA in Los Angeles. Our first learning objective will be to integrate best practices for initiating and switching antiretroviral therapy in patients based on safety and efficacy data. And our second objective will be to translate emerging data from national conferences and guidelines to treat decisions in clinical practice. Let me start by introducing you to Luke. Luke is a 41-year-old man who was diagnosed with HIV about 20 years ago. He's had many years of antiretroviral therapy experience with virologic failure on nucleoside reverse transcriptase inhibitors, a non-boosted protease inhibitor, non-nucleoside reverse transcriptase inhibitor, and an integrase strand transfer inhibitor. And with all of this experience, he's been persistently viremic, despite reporting good adherence at this time. Now, with all patients like this, it's very important to get a detailed history of their previous treatment. In his case, he started about 20 years ago on antiretroviral therapy regimen with zidovudine, lamivudine, and efavirenz. He experienced virologic failure, which was not uncommon with this regimen because of either poor adherence or perhaps at times poor tolerability to either the efavirenz with its CNS toxicity or some of the GI or other toxicities associated with zidovudine. And although a good regimen with poor adherence, there was the risk for failure, and he did indeed experience viral rebound on the regimen, and was then treated with newer drugs that became available, tenofovir disoproxil fumarate with emtricitabine, plus the non-boosted protease inhibitor nelfinavir. And during this time, he experienced a transient reduction in viral load and then rebound. And although we won't go into the details of his early failure, it is really worth noting that this was not an uncommon scenario. We had limited agents available 20 years ago or so, and this is somebody who at the time they failed their first regimen likely failed with some resistance, at least to lamivudine, which also causes resistance to emtricitabine. So in essence, when we started him on the new regimen, we started him on a regimen that included a non-boosted PI with a low barrier to resistance, with tenofovir, and probably no activity from the emtricitabine. So he ended up on a 2-drug regimen, one of which had a low barrier to resistance, and what was commonly seen at that time, even if the person took their medications consistently, was that they would experience viral rebound, and that's in fact what happened. After that, he changed his regimen and went to a 3-nucleoside regimen, often done at the time with the idea that we thought we needed to have ideally 3 fully active drugs in this case. So in this case, zidovudine and perhaps abacavir are susceptible, plus lopinavir ritonavir, a boosted PI, now a drug with a high barrier to resistance. And he did indeed suppress his virus for about a year, again, consistent with the regimen he was given. The problem was these kinds of regimens were associated with substantial toxicity. And he was complaining of mild diarrhea, and around that time, there were new classes of drugs that came along that had extremely potent and favorable tolerability profiles. So he was switched. Basically, the feeling was that the lopinavir ritonavir was causing some GI toxicity. Let's switch him to those nucleosides with raltegravir. At this time, he was virologically suppressed, and raltegravir was the first-in-class, extremely well-tolerated integrase inhibitor. The problem was it had a relatively low barrier to resistance, and he had already accumulated some underlying resistance. And that during the course of the treatment, drug resistance testing was performed several times while he was experiencing virologic failure. He also, about 2 years prior, had a tropism test sent because of consideration of using a CCR5 antagonist. and he was found to have a dual mixed tropic virus in his plasma. So his most recent regimen, when he presented to CARE after many, many years of treatment, over the last 8 months, he'd been on dolutegravir twice daily, darunavir ritonavir twice daily, etravirine, the second generation NNRTI twice daily, and tenofovir alafenamide emtricitabine, so the newer formulation of tenofovir once daily. So he's now on a regimen with 4 or 5 actual drugs. His recent viral load had consistently been in the 1,000 to 2,500 copy range on this regimen, despite the fact that he seemed to be pretty clear that he was taking the medications consistently. And his CD4 count at the time was running between around 220 and 300 cells per microliter. At his current clinic visit, his most recent regimen was, as noted, for about 8 months, the dolutegravir twice a day, darunavir ritonavir twice a day, etravirine twice a day, tenofovir alafenamide emtricitabine. So a fairly complicated regimen with a lot of drugs that are used in people who have underlying resistance. But despite this, he was experiencing ongoing virologic failure with viral loads repeatedly over 1,000 copies per mil, and the most recent one being 2,200 and a CD4 count of 275 cells per microliter. So when we think about virologic response, it is worth going back and discussing how we define this. And this is sort of a summary of the different groups we put people in. We talk about virologic suppression, which is our goal of therapy anytime we start it or switch to a new regimen. And that's to ideally get HIV RNA levels below the lower limits of detection. And that would be suppression. Virologic failure would be somebody who is unable to achieve or maintain suppression to a viral load of less than 200. So our goal is full suppression below limits of detection, but we only tend to think of virologic failure in those who are repeatedly above 200 copies per mil, because we know there are people who will live with intermittent viral levels between detectable level and 200. So that's virologic failure. You can think about incomplete virologic response in somebody who has 2 consecutive RNAs greater than 200 after a substantial period of time on a new regimen, whether it's a first-line regimen or a regimen that's changed as a result of virologic failure. If they're not undetectable by 24 weeks, they're not likely to get there. In fact, with most of our current regimens, people get to undetectable much quicker. So if they never get down to less than 200, they've had incomplete virologic response. Then there's those who have virologic suppression, but then rebound with viral loads, again, importantly, repeatedly above 200 copies per mil, not an isolated increase in levels. And then there's low-level viremia. And these are the individuals who have levels that are confirmed to be above the level of detection of the assay, whatever that assay happens to be, 20, 40, or 50 copies per mil, but less than 200. So that's low-level viremia. Those are people that in general, we don't think of as experiencing true virologic failure, and most of the time would choose to monitor them closely. And of course, in all these cases, reinforce appropriate adherence to therapy, and that they're taking their medications correctly, and that there are no important drug-drug or drug-food interactions. So when you look at this figure, you can see that we have the top and bottom are people that are not experiencing failure, and the group in the middle are experiencing failure in one form or another. So when we think about why people fail, and this is critically important before we make any decisions about a change in regimen, it's worth going through the various different factors. And I sort of alluded to some of them based on the history of Luke's treatment. So we have a variety of treatment-related factors that can drive this. And we always need to consider this because it doesn't make sense to modify a regimen if we can't overcome some of these obstacles to success. So there may be comorbid conditions that interfere with the patient's ability to take their medications, substance abuse, mental health problems. People have unstable housing or other psychosocial factors are clearly important. We have people who simply have difficulty adhering, not just with their medication, but with their clinic visits. They're not taking their medications consistently. And there may be a variety of reasons why this would be the case. Maybe they're having difficulties paying for their medications. Some people don't take their medications consistently because they're actually having side effects. So you really want to explore whether the person's having even mild side effects that might be interfering with their ability to consistently adhere. And then sometimes the dosing regimen is just complicated. Perhaps a lot of pills. Our patient was on a considerable number of pills, perhaps with complicated dosing frequencies or drug-drug or drug-food interactions that make it difficult for the person to take their medications consistently. Then there are the HIV-related issues that might drive virologic failure. Perhaps the transmitted or acquired drug-resistant virus. This has certainly contributed to some of the failures that Luke has experienced, probably starting way back when he first failed his efavirenz-based regimen and likely selected for resistance to lamivudine and emtricitabine. Prior treatment failures, again, in his case, it started with that. Subsequently, he failed a non-boosted PI, which is associated with selecting for protease resistance. He failed the first generation integrase inhibitor, raltegravir, associated often with the selection for drug resistance. And then there's things like higher treatment RNA at baseline, which for some regimens has an impact, although for most of the regimens we use in the current era, they all work just as well in people with high viral loads as low viral loads. And then antiretroviral therapies, we've alluded to this as well, perhaps poor pharmacokinetics. Mostly this is going to be related to things like drug-drug or drug-food interactions the patient's not paying attention to or hasn't been appropriately instructed how to address. Sometimes regimens are just simply not potent enough. And we probably saw that in the early days with Luke, where he had developed some underlying resistance. And when he transitioned to a new regimen, there was simply not enough potency within the regimen to maintain virologic suppression. And this is often the case in those who were treated with low barrier to resistance drugs, which was not uncommon back when we used NNRTIs, non-boosted PIs, first generation integrase inhibitors. Those were all low barrier drugs where if things didn't go right, for any one of a number of reasons, resistance was almost inevitable. This is less the case in people starting therapy in the last decade or so, as we've transitioned more to boosted PIs and second generation integrase inhibitors like bictegravir and dolutegravir that have high barriers to resistance. So resistance is much, much less likely. So let me ask a few questions that come up at this time point when we're meeting a new patient like Luke. The first one is, should further resistance testing be done? I mentioned that he had had resistance testing performed several times. We'll share those previous results with you. But at this point, he comes in, his viral load is consistently over 1,000. Should resistance testing be done? Well, in reality, anybody who's experiencing virologic failure on therapy should have resistance testing performed. Now, you will want to consider all previous resistance data because we know that any resistance virus selected for in the past is still going to be relevant for future regimens. Whether we detect it today or not, we know those resistant variants are persisting within the person's reservoir and can be selected for if we make a bad choice. But it is important on a person like this who's on a pretty big regimen with PIs, NNRTIs, nukes, and integrase inhibitors to know what level of resistance they have right now. So yes, resistance testing should be performed in a patient like this. So then the follow-up question is, when should it be done? Now, one of the important things about resistance testing is that it really is sensitive for detecting mutant virus that is resistant to the drugs that they're actively taking. So the best way to assess somebody's resistance pattern, especially to the regimen they're taking at this time, is while they're taking the current regimen, answer A. Once they stop that regimen or have viremia off of this regimen or on another regimen, the selection pressure changes. And you risk missing mutant virus that may be present, but is no longer being selected for. So you really want to do it while the patient's taking the regimen. And in general, in people experiencing virologic failure, the recommendations are to not discontinue their treatment. It's to address any concerns you have that might interfere with their success on a future regimen and to modify their regimen to one that's likely to be active against the viruses present in their system. And we know from previous studies many years ago that if you interrupt therapy, they will experience viral rebound to a higher level and CD4 decline and disease progression. So in this case, clearly the best answer is A. Okay, so we agree resistance testing should be done and that it should be done while they're on their current regimen. What type of test should it be? Well, we already talked about D and that resistance testing really should be done. And in this case, probably the best answer is C. A genotype will definitely provide useful information, as will a phenotype. The settings in which we generally get phenotypes are those people who actually are known to have or suspected to have complicated resistance patterns, particularly to protease inhibitors. The phenotype may give us some insight in those who have lots of mutations as to whether there may be at least intermediate activity to a certain drug. So a phenotype has a role, a genotype may complement it as well, because it provides you somewhat different information, perhaps a little bit more sensitive for mutations associated with resistance. So in general, for people who don't have or are not anticipated to have complicated resistance patterns, perhaps looking for transmitted resistance or failed 1 or 2 regimens, a genotype is the right answer. Rarely do I think a phenotype is the right answer alone. And genotype phenotype in these really complicated cases who've experienced virologic failure on multiple classes, including non-boosted PIs where they're at risk for having selected for a lot of protease resistance. I think a genotype and phenotype is probably the best answer here. And should a tropism test be performed? So the role of a tropism test are for those individuals in which you're considering using a CCR5 antagonist, which right now, the available drug is Maraviroc. And the situation in which you'd be considering doing that is somebody who's likely to have multi-class resistant virus, where you're going to be trying to put together a new regimen with as many active drugs as possible. In somebody like this who's failed nukes, non-nukes, PIs, and integrase inhibitors, I think it's likely they're going to have multi-class resistant virus. And as I'll show you in a moment from his treatment resistance data from the past, he does. This is a setting where a CCR5 antagonist, Maraviroc, would be considered. However, with the tropism test, you're looking for the presence of virus that does not use CXCR4. So primarily, you're looking for a CCR5 tropic virus, or R5 only. If there's any evidence now or in the past of a CXCR4 using virus, which usually reports as dual mixed tropism, then a CCR5 antagonist will not be an active drug. Since this person, just like looking at resistance data in the past, since this person had a tropism test 2 years ago that showed dual mixed virus, we know they have within their population of viruses a CXCR4 using virus. And therefore they are not a candidate for Maraviroc, and there is no need to perform another tropism test because we already have the answer to the question. So the best answer here is no. So let's talk about managing somebody with virologic failure. This clearly doesn't apply to Luke, but it's worth talking a little bit about managing failure of first-line regimens. And most of our first-line regimens are NNRTIs, integrase inhibitors, or boosted PIs. And we have reasonably good data showing that when people fail a boosted PI-based regimen in the current era, they generally have very little or no underlying resistance. It is mostly a result of poor adherence. And there may be a variety of reasons for it, but the recommendations are to simply reinforce adherence or consider modifying the therapy to something that will be perhaps more convenient or better tolerated. For NNRTI failures, we actually have several large randomized control trials that have informed this decision. And our options in this case, where the person is likely to have resistance to the NNRTI and to lamivudine or emtricitabine, we have very good data showing that if you use dolutegravir plus nukes, and it says here in the most recent guidelines if one is fully active, but there was recent data published in the New England Journal on the Nadia trial that showed a fully active dolutegravir plus even nukes with underlying resistance is highly likely to achieve virologic suppression. Boosted PIs plus nukes, ideally you'd have one that's resistant, but we have very good data showing that even if none of them are fully active, that this regimen is highly likely to suppress viral load. And then a boosted PI plus an active integrase inhibitor. So these are three options for which we have a tremendous amount of data. And what we've learned from these studies is that dolutegravir with even nukes with resistance and boosted PIs with nukes with resistance are very active in achieving viral suppression. And then finally, integrase failures. The interesting thing here is this is the most common first-line regimen we use now, is integrase-based therapy, but we have the least data in how to manage them when they fail. In general, most people on an integrase inhibitor who experience virologic failure in the current era with dolutegravir and bictegravir will have no integrase resistance and rarely any resistance to lamivudine or emtricitabine. So these people can almost certainly be managed with a boosted PI plus nukes, ideally one active, but not necessarily, or a boosted PI with an active integrase. Perhaps they have resistance to first generation integrase, but not to the second generation integrase inhibitor. These regimens are likely to work. So lots of options for first line failure. Obviously, Luke doesn't fall into this category. This is a figure that sort of walks us through the approach we can use for second line and beyond. And Luke definitely falls in the category of beyond. And really the branch point is, do they have susceptibility to boosted PIs or dolutegravir? Because as you recall from the previous slide, if you have a fully active boosted PI or a fully active dolutegravir, and probably this applies to bictegravir as well, that you have lots of options because those drugs, even with nukes with underlying resistance, will achieve good suppression. So if you have susceptibility to both of those, you can use dolutegravir with 2 nukes, a boosted PI with 2 nukes, or a boosted PI with active integrase. And all of those regimens are likely to work. If you have activity to the PI, but some integrase resistance, probably the optimal regimen would be the boosted PI with nukes. Ideally one active, but even if neither of them are active, there's a very high rate of viral suppression. If you don't have activity to the PI, but you do to dolutegravir, and again, this probably applies to bictegravir as well, we just have less data in treatment experienced patients. We know dolutegravir with 2 nukes, and we know from the Nadia trial, even if those 2 nukes aren't fully active, is highly likely to achieve virologic suppression. Now, if you don't have dolutegravir with 2 nukes, then you might be looking at sort of the guidance that we've used for years. And that's ideally 2 and preferably 3 fully active drugs in combination. And when you've got somebody who is highly treatment experienced to multiple classes and has documented or suspected resistance to both the PI and dolutegravir, then the regimen usually that you'll choose will be one that will be constructed to have 2 and preferably 3 fully active drugs. So to find out where we are in this algorithm, we need to understand what Luke's underlying resistance pattern is. So here is this cumulative drug resistance history, and this is really important. You look at everything, not just the resistance data at this point, but everything that's been collected in the past, plus what you identify when you do your resistance testing today. And from the nukes perspective, he has the thymidine analog mutations that we don't see much anymore, but we did when we started people on zidovudine like he was. And the 184V, which confers resistance to emtricitabine and lamivudine. And the predicted susceptibility, in this case, I learned this from just plugging it into the Stanford database, which is a fantastic resource if you've not used it. It predicts that abacavir and tenofovir will be intermediate susceptible, not fully active, but intermediate. For the non-nukes, there's the 103N and the 188L, and the predicted susceptibility is etravirine might have low-level resistance. From the protease perspective, he has the D30N, which for those of us who've been around long enough, we know that was the signature mutation for people failing nelfinavir, and multiple other important mutations. And ultimately, the predicted susceptibility was that darunavir and atazanavir may have intermediate susceptibility. For integrase, he had the 140S and the 148H, likely selected for when he failed raltegravir, And again, the predicted susceptibility is intermediate for the second generation INSTIs, dolutegravir and bictegravir. And then finally, we know he had a history of a dual mixed tropic virus, meaning that Maraviroc would not be an active drug. So when we look across these 5 classes of drugs, we can see that there are no fully active drugs predicted. So we have multiple intermediate active drugs. So we don't have a fully active integrase. We don't have a fully active boosted PI. So we're going to really rely in Luke's case, like we often do in these highly treatment experienced patients, with trying to construct a regimen with 2 and preferably 3 fully active drugs, often with some intermediate active drugs as well. Keeping in mind, we want a regimen that will be active, but also one that will be relatively easy to take and well tolerated. So fortunately, we have several new drugs that are actually approved and available for these kinds of patients. The first one, which is the most recently of the approved drugs, is fostemsavir. This is a prodrug of temsivir, and it actually binds GP120 and blocks attachment. So it's a new drug in a new class. So underlying resistance to those previous classes has no impact on this drug. The initial primary endpoint for these drugs for highly treatment experienced patients is to simply show intrinsic activity, and that's what they did. They added it onto a failing regimen and showed in the first week a significant reduction in viral load. So it works. And then they continue it with optimized background regimen. In this randomized cohort, which are people who had at least one other active drug to use with it, you can see that over 60% of people achieve viral loads of less than 40, despite these people like Luke having multi-class resistant virus. And this is given orally twice a day. And then ibalizumab, approved a couple of years ago, is another new drug in a new class. It's a humanized monoclonal antibody that binds to CD4 and blocks a post-attachment event. And the pivotal phase 3 trial for highly treatment experienced patients, similar to what I described before, was to simply take somebody experiencing virologic failure, give them an infusion of the monoclonal antibody and see what happens to the viral load over the course of a week. That documents the intrinsic activity, and it showed that it was indeed an active drug. And then give them optimized background with continuation of ibalizumab, which tells us how active it would be in a setting with other drugs, as well as an opportunity to learn more about its safety. And here is some of the data that's available, looking at the proportion of people with viral loads of less than 50 and less than 200, 45 to 50%, again, in a population of highly treatment experienced patients. Now, this is given as an infusion every 2 weeks, but it is another option, a new drug in a new class. So when thinking about putting together a regimen with at least 2 fully active drugs, now, because of these new drugs, we have ibalizumab and fostemsavir that could perhaps be combined with a few of the other drugs that could be taken without a lot of difficulties with tolerability or convenience. There are other drugs on the horizon. This is one worth discussing because there's new data in highly treatment experienced patients, although this is not yet approved. This is lenacapavir. It's a first-in-class novel HIV capsid inhibitor. So again, a completely new class. So underlying resistance to any of the other classes does not confer resistance to this drug. The other advantage of this drug is it can be given as a subcutaneous injection every 6 months. So it's being developed for first-line therapy, highly treatment experienced patients, and even for prevention. But we're going to focus on that highly treatment group. And it works at several different steps in the viral life cycle. So this is the key study that's recently been reported. This took people who were experiencing virologic failure, resistant to at least 2 agents from 3 of 4 main antiretroviral classes, and had limited options. And it randomized them to stay on their failing regimen for 14 days, or to receive oral lenacapavir given on day 1 and 2, and then day 8, and simply assess the intrinsic activity of the drug. The primary endpoint was the proportion of people with greater than a half log reduction in viral load after 14 days. After that, they received optimized background regimen with subcutaneous lenacapavir with follow-up for safety and virologic suppression. Here's the primary endpoint data, 88 versus 17% achieved that greater than a half a log. And you can see that the mean change in viral load in those who received lenacapavir on top of their failing regimen was almost 2 logs. So a highly potent new option that has a long-acting capabilities. And then recently at the IAS meeting, there was data presented from this Capella study in highly treatment-experienced patient, which was the follow-up data, looking at week 26 in relatively small numbers to see what proportion of people who received subcutaneous lenacapavir, along with optimized background, these are highly treatment-experienced patients, achieved viral loads of less than 50. And you can see that it was approximately 80% were able to achieve virologic suppression. So a drug not yet approved, but in the advanced stages of development for highly treatment-experienced patients. And there are other drugs also in earlier stages of development for this patient population. So with that, I want to walk through our SMART goals: specific, measurable, attainable, and relevant, and timely goals that we've learned, hopefully, from Luke. Identify patient-related, HIV-related, and antiretroviral therapy regimen-related factors that may be contributing to virologic failure and drug resistance before you do anything. But this is an extremely important first step when seeing somebody with virologic failure. You want to apply guideline recommended algorithms to clinical decisions and thinking about what you're going to do next after thoroughly assessing what underlying resistance they're likely to have acquired during the course of their previous therapy and have on their current regimen. You want to assess the efficacy and safety data of agents to determine what their role may be in managing patients with multi-drug resistant virus. And fortunately, we have 2 relatively recently approved new options and more on the way. And then ultimately evaluate the efficacy and safety of these agents in the latest stages of development for these patients, either to try to employ right now, if currently available, or perhaps pursue through expanded access programs, if available by the companies, and to keep in mind for future regimen for the individual. Today's CMEO briefcase is part of a 3-part series of case-based activities that can be found on the Infectious Diseases Hub at cmeooutfitters.com. I hope you'll check out the other 2 activities in the series. The Infectious Disease Hub has these activities and many other activities on HIV. CME Outfitters also has an HIV patient education hub with a number of excellent resources, videos, whiteboards, and to share ultimately with your patients. And finally, I want to thank you for joining me today. Don't forget to complete the post-test evaluation. And as a reminder, this activity is also available for ABIM MOC credit. Stay safe. Thank you again for participating in this CME activity and providing the best care for your patients.